So I'm Mike Tannenbaum. I'm the Provost and Vice President for Academic Affairs at Hartwick. I'm also, by academic training, a biologist. Therefore, it gives me great pleasure to welcome all of you to the inaugural Dr. E. Robert Burns Class of 61 Biology Lecture. This is a watershed for Hartwick. Endowed lectures like this one provide the Hartwick community an opportunity to listen together, to learn together, to ask questions together. We're grateful to Dr. Burns and other alumni who have chosen to invest in Hartwick by advancing our shared knowledge in this way. Dr. Burns established this lecture series in 2013 to bring to the Hartwick campus a prominent speaker to share ideas about emerging topics pertinent to the field of biology. Dr. Burns himself is an accomplished educator and researcher who majored in biology at Hartwick, then earned a master's degree in zoology from the University of Maine and a doctorate in anatomy from Tulane University Medical School. He then accepted a postdoctoral position with the National Institutes of Health at the George Washington University Department of Pathology. An award-winning educator, noted researcher, and prolific author, Dr. Burns is Professor Emeritus at the University of Arkansas for Medical Sciences in the Division of Interdisciplinary Toxicology. Hartwick College is proud to have recognized him as a distinguished alumnus. Now, while Dr. Burns is unable to be with us here tonight, we're fortunate that he has recorded a message that we're going to hear from him now.
Hello and welcome to this lecture. I'm Bob Burns, a 1961 graduate from Hartwick College. I'm currently Professor Emeritus in the College of Medicine Department of Neurobiology and Developmental Sciences, the University of Arkansas for Medical Sciences. And I've established this lecture to honor and thank Hartwick for the great undergraduate education I got at Hartwick. I'm kind of a naive, goofy kid from Catskill, New York, and Hartwick set me straight. And the farther away I get from my education at Hartwick, the more important it becomes. After leaving Hartwick, I got a master's degree in zoology from the University of Maine. After that, a PhD from the Department of Anatomy at Tulane University School of Medicine. After that, I completed an NIH postdoctoral fellowship in cancer pathology at the George Washington University. And all of those steps, as I migrated through those different steps in my education, were made possible in large part because of the great education I got at Hartwick College. I have several awards. Early in my research career, I had a National Cancer Institute Research Career Development Award. I have teaching awards, the Chancellor's Teaching Award, the Dean of the College of Medicine Master Teacher Award, and for 3 years I held the Luderloh Professor of Medical Education Excellence. Of all of those, the one I'm most proud of is being selected as the Distinguished Alumnus, Hartwick College, 1988. So this is my way of thanking Hartwick for the excellent education she gave me. Please go ahead and enjoy the lecture.
Well, good evening and welcome to the lecture. Last night I was thinking about preparing my introduction of our speaker, and I thought I have to do two things to do this well. One is keep it short, and the other one is to memorize it. So I'm going to do neither, because our speaker's background is so amazing that I can't possibly keep it short, nor could I possibly memorize it. My name is Peter Fouth. I'm the chairman of the biology department, and I welcome you to our first Dr. E. Robert Burns Endowed biology lecture. And it will be presented by Dr. Burton Wilcke. So Dr. Wilcke graduated as a biology major from Hartwick in 1969. And that happens to be the same year that Hartwick bought its first computer. Check our website, there's some interesting history there. And it was 2 years before the Pine Lake Environmental Campus was purchased by Hartwick College. It was an interesting time. We talked a little bit about this because this was a time where students were very active in protests about Vietnam and the war. After leaving Hartwick, Dr. Wilcke completed a master's degree in what we would now call microbiology and public health from Wagner College in 1971, and a PhD in immunology and microbiology at the School of Medicine, Temple University in 1976. After completing a 2-year postdoctoral fellowship in medical and public health microbiology with the California Department of Health, Dr. Wilcke began a distinguished career that involved both academic and public health appointments, often at the same time. From 1982 to 1983, for example, Dr. Wilcke was an assistant professor in the Department of Pediatrics and Human Development, College of Human Medicine at Michigan State University, and at the same time, he served as the deputy chief of the Division of Virology in the Michigan Department of Public Health. From Michigan, Dr. Wilcke moved west to become the laboratory director of the San Bernardino County Department of Public Health, and also served as an adjunct professor at California State University during the same time. So more recently, Dr. Wilcke was the director of the Division of Health Surveillance in the Vermont Department of Health from 1995 to 2002, before becoming an associate professor, Department of Medical Laboratory and Radiation Sciences in the College of Nursing and Health Sciences at the University of Vermont from 2002 to his retirement in 2017. During his time at UVM, Dr. Wilcke served in the role of the chairman of the Department of Medical Laboratory and Radiation Sciences for 12 years. That alone, I think, is a major accomplishment. And I know there are others here that probably are feeling the same thing. He served on numerous committees and boards of national health and public organizations, such as the Clinical Laboratory Management Association, the American Public Health Association, the American Society for Microbiology, the Association of Public Health Laboratories, and in that case, serving as its president. Dr. Wilcke is the author of numerous publications and served on the editorial board of journals such as Emerging Infectious Diseases, African Journal of Laboratory Medicine, and Public Health Reports. He is currently faculty emeritus at the University of Vermont and currently sits on the accreditation committee of the Public Health Accreditation Board, on the American Board of Bioanalysis, and the board of the Vermont Public Health Association. I really could continue listing many of Dr. Wilcke's accomplishments and use up several more minutes, but instead I ask you to join me in welcoming Dr. Burton Wilcke, who will present the Dr. E. Robert Burns Endowed Biology Lecture on, and his topic is Global Health Challenges, the Role of Laboratory Sciences. Dr. Wilcke.
Thank you very much for that kind introduction. I'm going to apologize at the outset because as a professor and teaching classes for a number of years, it almost became intuitive as to how long you need to prepare and what you need to prepare and how many pages to reach, whether the course was an hour-long lecture or an hour and a half. And it just was amazing to me because it kind of fell into place. I realized I haven't done that for a year and a half. And I also realized that when I was giving lectures at the University of Vermont, I normally had but a few hours to prepare my lectures. And with this, when I was first contacted about doing this, it was months ago. And the only fault I will give you is that's too much time. I had so much time to think about what I was going to say this evening. And so if anything, I probably I have too much on my talk. If I do, I'll just truncate it and we can go into the Q&A. So I'll apologize ahead of time. It is indeed a pleasure to be here. Hartwick, of course, is my alma mater. And I really want to thank Dr. Burns. I've never had the privilege of meeting Dr. Burns, but I think it's wonderful that he's doing this, and I think it's a great gesture on his part to do this. And to be here giving the inaugural lecture is deeply humbling for me to do so. I also want to thank President Dragovich. I was here about do we decide? Maybe 7, 8, 9 years ago, I can't recall. And we had a very nice exchange then. And then she visited me at UVM one time. We had a very nice time during that conversation. And so I feel that she's done an outstanding job at Hartwick College. And I think it makes me proud as an alumnus to see the stature of Hartwick College climbing among liberal arts colleges. It's truly impressive, and I appreciate what she's done. I would also like to thank Dr. Falk and also Joanna Casiola, who have both been very kind in helping to arrange for this visit. I have very fond memories of Hartwick. I was thinking about this today as Dominique gave me a tour of the campus, and it made me think of the song Good Vibrations, which I think, was that Beatles? Was there Beach Boys? Was it Beach Boys? Yeah, in the 60s. And so I felt good vibrations walking around the Hartwick campus. So it still has that impact on me. I feel like I had, as Dr. Burns said before me, an excellent foundational education here, and that has served me well throughout my career, both in public health and academia. My topic this evening is one that's dear to my heart. It's an area that I really love, and it gives me great satisfaction and challenges, personal challenges, and it's an area which hopefully in this evening's discussion will stimulate such kind of feelings in you as well about what needs to be done and what can be done in the area of global health. At the University of Vermont, I was teaching global health, and I did that for about 15 years. And in addition to teaching it, I had started working in the area of public health back in 1993 was the first global health experience I had. I'm still engaged in global health, and as I say, it's an area which I love deeply. The changes that are occurring in global health now are significant. And you'll see if you read about global health that we've moved away from some of the challenges of communicable diseases to non-communicable diseases. What that really means is that in some places where communicable diseases have been so difficult to deal with, as we deal with them and as people tend to address those or not have those diseases and are treated for those diseases, that these underlying diseases of diabetes and cancer and chronic obstructive lung disease, respiratory disease, kind of crop up. And so those are coming about now, but I'm going to focus on communicable diseases. That's the area that I'm most familiar with, and it's the area that I enjoy the most. I'm going to talk about what global health is. We're going to talk about emerging infections that are confronting us on a global scale. I want to talk about antimicrobial resistance and the serious problem that poses for us. And I want to talk a little bit about One Health. But first, before we do that, I wanted to take you on a little journey which covers the time period between, actually all the way back to my high school days and today. Shortly after I was at the University of Vermont, in 2002, I had a student who was an advisee of mine come in and interview me. That was an assignment that she had, was to interview her advisor and find out something about the career path that, in this case, he took and how he ended up teaching at the University of Vermont. And this was what she gave me. After a few days, she came back and she shared her interview with me, and she gave me this kind of outline, which reminds me of the game of life, where you kind of follow this pathway around the board. So this is what she showed as my pathway, my career pathway. As you can see, I started at Michigan State University. I don't know why I did that. I was young. I graduated very young. My brother was in pre-vet at the time not there but elsewhere, and I had this kind of notion that maybe if that was good for him, he was my older brother, I admired what he did, it was good for me. I was there for about a year, and I was quite overwhelmed. Michigan State had 45,000 students, and I had graduated from a school that had a high school graduation class of 52. And so I just didn't feel like that was the right fit for me. I left there at the beginning of my second year, and I came back to the Albany, New York area, which is where I grew up, and started working at a hospital. But I wanted to find where I wanted to go next to college. And so there was a little bit of pressure going on, as Dr. Fouth mentioned. This was about the time when the U.S. was kind of ramping up its decision to get more involved in Vietnam, and so there was an incentive for me to look pretty quickly at what my options were. I had a good friend from high school who had decided to go to Hartwick and went to Hartwick out of high school, and he contacted me and said, this is a great place. You should consider, coming to Hartwick. So I followed his advice, and I did apply to Hartwick, and I was accepted, and I came here starting in January of 1966, I believe it was. I was a biology major, and I had some great courses and some great professors. But the course that really kind of stuck out for me in terms of my interest from the biological standpoint was a bacteriology course. And I just found it fascinating about the history of bacteriology, the range of organisms which goes beyond bacteriology, obviously to include viruses and fungi and parasites. It was just a fascinating field for me. So I decided that I would, at graduation, before graduation of course, look at other options to continue my interest in this field. I had spent a summer at Wagner one time, I think it was in '67, and took some courses which I needed to make up during the summer to allow for my transfer from Michigan State to Hartwick. So I had been there, and I was familiar with their campus, which, by the way, is beautiful, but not as beautiful as Hartwick's. Hartwick has one of the more beautiful campuses in the country, I would say. So I enrolled in their bacteriology and public health program. Now, you remember, this is 1969. I just graduated from Hartwick. 1969 was referred to as the summer of love. It was the summer of Woodstock. So, having been shot by the arrow of Cupid, my wife and I got married. We actually eloped just before we started in Wagner. And that probably wasn't the smartest thing from a financial standpoint, but it worked out okay because we're going to celebrate our 50th this summer. My experience at Wagner really was great because I was studying a field that I loved. I was able to teach undergraduates bacteriology in the laboratory because I had a teaching fellowship. I secured a part-time position at a clinical laboratory in Brooklyn, Maimonides Medical Center. So I got to experience clinical microbiology as well. And I really got my first taste of public health. So it was a great experience. When I was finishing up at Wagner in that year or two, 70, 71, I realized that I really wanted to take this further. And so I looked into what my options were to pursue a degree at the PhD level. And so the best opportunity for me, as it turned out, was at Temple University, just not too far down the road in Philadelphia, at the medical school, where they had a program which included in the program an exposure to immunology and bacterial and microbial physiology and genetics, but also a focus on infectious diseases and medical microbiology. So that was where I ended up. And that was also a very good experience for me. I, of course, as a PhD student, had a research component to my degree, and I ended up working with a professor who was a professor in the College of Medicine, Department of Microbiology, but also he was the head of the clinical laboratory for the hospital, Temple University Hospital. I worked on in my PhD dissertation pathogenic mechanisms of certain strains of Pseudomonas aeruginosa. And these were Pseudomonas aeruginosa strains that were derived from kids with cystic fibrosis. Pseudomonas aeruginosa is kind of an opportunistic bacterium that preferentially kind of colonizes the airway passages of children with cystic fibrosis. So I spent a couple of years studying about that, and I did describe some things which had previously been unreported, and so it was fulfilling in that regard, but I realized that basic research was really not where I wanted to spend my time. So as I finished my PhD, I was looking into opportunities to go into a clinical microbiology pathway where I could end up doing just exactly what my mentor was doing, and that was running a clinical laboratory in an academic health center. But for that, I needed a postdoctoral fellowship, and so I looked into those. At the time, there were about 15 of those around the country, and so they were somewhat competitive. I was fortunate to be able to choose from 3. I could have gone to Baylor University in Texas. I could have gone to the University of Washington in Seattle. Or there was one which was kind of unusual, different than the rest, because it wasn't at an academic health center, it was at a state health department, in this case, California. The key, however, was a financial and personal one. So California could promise me 2 years of a postdoctoral stipend. Baylor and Washington both said they could promise me 1 year, and they were fairly certain that they could provide me the second year. But we had our first daughter at the time, and we were expecting our second daughter, so having 2 years of a secured income was a no-brainer for me. So we took off for California. That experience in California really changed my career trajectory. I really didn't have any good knowledge, I would say, about the breadth of the field of public health until I got to California. I got to interact with epidemiologists. I had never interacted with epidemiologists before. It was really an excellent learning experience. Every week we would have these laboratory and epidemiology conferences. And it was there that I learned about, for the first time, a syndrome, which I mentioned today in the public health capstone course group, about called Floppy baby syndrome. And you may have heard of that, or you may remember that it's a disease now referred to as infant botulism. But the first cases were being identified at that time in the San Francisco Bay Area. And some of the work that I did in California while I was there for 2 years involved looking at that syndrome. It was really interesting because the clinicians had no clue what it was. It looked like botulism, but there was no evidence that the children had taken in any foods that might have had botulinum toxin. There was no wounds that would have caused botulinum toxemia. So the laboratory at the California Health Department, which was the food laboratory that normally tests for botulism, looked first at the serum of some of these infants, didn't find any botulinum toxin, and then one of the laboratory scientists said, let's take a look in the stool specimen of these babies. And sure enough, every one of those babies had botulinum toxin growing, or not growing, but evident in their stool specimens, so in their guts. It took a while to figure this out, but what was the end of the investigation revealed that infants take a while, as you may know, because there's a lot of work now being done on the microbial gut flora. And infants take a while to develop the gut flora and stabilize the gut flora. And so what was happening is that somehow they were getting spores of Clostridium botulinum into their intestines before their gut flora was stabilized enough to kind of cause them to be passed off or passed through. Those spores then, in that setting, were able to generate vegetative cells and then toxin and give these children what was a case of flaccid paralysis. In some cases, severe enough to put them on respirators and be life-threatening. You may all know now that if you look at a jar of honey, that the jar of honey will say not to feed it to children under 1 year of age, and that's because of infant botulism. the spores of Clostridium botulinum can be found in that honey and tend not to create any problems for children over 1 or for anybody else, for that matter, adults who take in those spores. We probably all have Clostridium botulinum and other Clostridium spores passing through us, regularly. Fascinating subject and a fascinating example of how clinical science and epidemiological science and laboratory science interact. I also remember sitting at one of those meetings with the epidemiologists and hearing about a disease which was occurring back in Philadelphia, the city of where Temple is located and where I had been studying for 4 years. So in Philadelphia, they had an outbreak at this hotel, and it was an outbreak among people who were attending a Legionnaires convention. And so it was mystifying to them because all of the laboratory work and all the clinical diagnostic work that was being done didn't reveal a diagnosis. And so it became called Legionnaires' disease as kind of a descriptor. And it took a while for anybody to realize what happened. What finally happened is a scientist at the CDC, Dr. Joe McDade, took some samples from these patients and put them into guinea pigs. So that's a practice which you don't normally do for bacterial infections, but you might do it for rickettsial infections. And so by doing so, he was able to identify the organism, which was newly recognized. No one had seen this organism before. It became known eventually as Legionella, and actually it's Legionella pneumophila is the most common strain. There's actually a strain or a substrain which is named after Dr. McDade now. Another example to me of how public health, in this case, public health laboratory science at the highest level in the US, that's at CDC, was able to solve this kind of communicable disease mystery. After I left my postdoc at California, I went to Michigan, as was mentioned by Dr. Fouth, and I first oversaw a TB laboratory, and then I went into the virology laboratory, and it was in the virology laboratory that I set up a test for chlamydia. So chlamydia is a bacterium, but it's a bacterium without a cell wall. And so people had often thought about it as more as a virus or a potential virus because you can grow it in cell culture just like you can grow viruses in cell culture. So we set that up, a chlamydia testing laboratory, and immediately started to see the results of that testing and showing that a large number of cases of sexually acquired cervicitis and urethritis were being caused by chlamydia. Prior to that, and this was not me only, a lot of people were showing this, that at the time that prior to that, gonorrhea was thought to be the primary agent of those conditions. Well, it so happens at that time that there was a veterinarian at the University of Michigan Medical School, and this veterinarian was in charge of the laboratory animals there and caring for the laboratory animals. And they were doing some work on frogs, African clawed frogs. And there was a die-off in their tanks, and they noticed that on pathology they saw vacuoles which they thought looked very much like chlamydia vacuoles. But no one had ever reported chlamydia as being a disease-causing organism of amphibians. And so we worked together and we collaboratively worked and isolated chlamydia. Originally we thought it was psittaci. I think it's since been described as a closely related but new species of chlamydia. And we published. So it was the first published account of chlamydia causing disease in amphibians, which didn't impress my family at all, but it might impress you, right? I found that to be kind of interesting. It was about the same time, though, that what relates to me in thinking about the chlamydia story is that scientists should always be open to the idea that something that hasn't previously been discovered is possible. In this case, finding chlamydia in amphibians. reminded me of, at the same time when I was in Michigan, we had heard about this disease, AIDS, and some people thought this was an aberration. Some people thought it was restricted to a small group of individuals. Some people thought it was possibly something that jumped species from other primates and would just burn out in the human population. But as we all know, that didn't happen. And it became known that human immunodeficiency virus, the causative agent, has created one of the worst epidemics in humankind. So keeping one's mind open, I think, in terms of host range and possibilities is an important thing. After working in Michigan, then I went back to California, worked in San Bernardino. It was there that when I was there, the first tests for HIV were introduced. So this was in March of 1985. In March of 1985, the first tests which were approved by the FDA could be offered to test for HIV. The problem was that testing for HIV resulted in finding out whether you were positive for the virus, but it didn't result in anything being done other than palliative care because there was no treatment. There were no antiretrovirals, and there wouldn't be for another 10 years. So that was obviously depressing, to be able to diagnose something from a laboratory standpoint but not be able to do anything about the disease. After I left San Bernardino, I came back east and went to Vermont and took the position of the state laboratory director. And while I was there, I developed a close working relationship with the epidemiologist, state epidemiologist. And one of the things that the epidemiologist does in consultation with others is to create a list of reportable diseases. So you keep track of reportable diseases for a variety of reasons. You want to find out how many cases of it you might have. You look into options as to how you can prevent it, treat it, deal with it as a public health problem. So prior to early 90s, chlamydia was not a reportable disease. So this is not chlamydia psittaci, but it's chlamydia trachomatis, which is the causative agent of these sexually transmitted cases. It was after the first year that we created chlamydia reporting as a requirement that chlamydia became the highest reported disease, communicable disease in Vermont. So it was clearly needed to report it, and it clearly identified a problem which showed that most cases were in adolescents, most cases were in people who didn't understand that there was a disease other than gonorrhea that could cause similar symptoms. And it was also pointed out that, found by us as well as by numerous others, that a huge percentage of cases were asymptomatic, meaning that individuals didn't have any symptoms of the disease, yet they were carrying the organism. So it was another important kind of eye-opener for me in terms of what public health can do. I, as I say, became the health laboratory director in Vermont, but then I did move into the position of Director of Health Surveillance. I am always amused by what the student put up there on the right side here, where it says State Health Surveillance Director. I think she thought I was some kind of royalty, which was not the case at all. So the nice aspect of that was that it included not just the laboratory, but epidemiology and biostatistics. So that, I think, could have been under somebody else's leadership, but under my leadership, as it turns out, was able to bring these three disciplines together and really, I think, further kind of move things forward in terms of the work that we did in Vermont. One of the cases in Vermont which was striking for me in terms of the relationship of epidemiology and disease control experts and the laboratory was a case of food poisoning which occurred in a restaurant which had a huge salad bar. So this restaurant, very well known, large restaurant, served a lot of people. We saw hundreds of cases of gastroenteritis caused, and the epidemiologists found out that it all came back to this restaurant. And then upon further food histories, the epidemiologists, what they do is they try to get the food if they can, which is sometimes difficult because if the occasion of the outbreak occurs several days after the food was consumed, you may not get the food samples at all. But in this case, they were able to get some food samples off the salad bar because the salad bar was implicated. But then the strange thing was that the food item that was most implicated on the salad bar was hard-boiled eggs. It makes no sense that hard-boiled eggs would have salmonella because hard-boiling the egg would kill any salmonella which was either in or on the egg. But that's what the laboratory results showed. And so it kind of forced the epidemiologists to go back and further query as to how this happened. And the story is that, and this was serious, this was an outbreak which actually people died from. There were individuals, some with HIV because their immune system was compromised, and ate at the restaurant and died as a result of salmonellosis. So what the epidemiologists found after serious inquiry, I think, and probably having to use almost police-like force, I think, to have these people tell what they did to explain this mystery. The restaurant had inappropriately, and as it turns out illegally, turned to their egg supplier and asked them, or the egg supplier offered and the restaurant decided to accept them on the offer, that they could simply bring in hard-boiled eggs rather than the raw eggs, then the restaurant wouldn't have to bother to take the time to boil them and peel them. So that's what happened. So we had farm workers who were collecting eggs, boiling them in a farm setting where you have all kinds of opportunity to contaminate them with salmonella. They were peeling them at the farm, putting them into buckets, transporting them unrefrigerated to the restaurant. When the restaurant got them, they put them into the cooler, but it's too late by then. And so then they pull them out of the cooler, cut them up, put them on the salad bar. So it was bad. It was bad for the egg producer. It was bad for the restaurant. It was obviously bad for the individuals who got sick and in some cases died. After my time at the health department in 2002, I decided, with the offer presented to me, to go to the university. I'd always wanted to end up in academia, and so it was perfect. And for us, on a personal level, it didn't involve moving across the country, as all my previous moves had resulted in. So I was able to stay in the same house and then just take my new position at the University of Vermont. That's been really rewarding, and so I've been able to help introduce some public health undergraduate courses at the University of Vermont. I was able to introduce a concentration within the medical laboratory science major and work with medical students on community public health projects. It was just a great way to finish my career in public health. One of the things that the university allowed me to do, which actually state government in Vermont was not too keen on, was to do global health work. It's kind of interesting that the state government doesn't necessarily think that's the role of somebody who's a state employee, but the university feels that doing global health work is appropriate and good, and if it's part of your academic inquiries and your social mission, that's very positive for the university, and you can inform your teaching. So I did a lot more global health work after I went to the university in Zimbabwe and in Central America and Namibia, Tanzania, etc. So we are at the point of essentially today. And now I want to step back. I want to step back to this time in the early 70s, the time when I went to Temple University, came out of Wagner and went to Temple University. I would say that was a time of serious complacency on the part of many in the health field, and particularly in public health. The 1960s were actually kind of a banner decade in terms of developing antimicrobials, developing immunizations, improving medical and public health care. And in fact, we were moving towards the reduction, in some cases, the total elimination of certain diseases in the North American hemisphere. The Surgeon General, William Lewis, I believe his name was, stated something to the effect around 1970 that it was time to close the book on infectious diseases. A little premature, some would say, because that obviously was not the case. It wasn't time to close the book. What we were missing then, and we often miss, is the wisdom of those that go before us. For those of you in microbiology, there's actually a Bourdet-Jeanjou, either stain or Auger, I can't recall which, but so Bourdet is known in the bacteriological fields. 110 years ago, he says, bacteria are highly adaptable. They frequently change both morphologically and functionally. Their virulence is also an essentially fluctuating property that increases or diminishes according to the conditions to which the pathogenic organism is subjected. So the problems that humans face and the challenges that ever-changing microbes present for us was recognized by him in 1910. This time period in the 70s was the time period that resulted in this huge influx of new diseases, new presentations of old diseases, all kinds of problems. This would occur for a couple of decades before this journal of emerging infectious diseases came out. And the individual who was the founding editor of that is that same individual I mentioned before, Dr. Joe McDade from the CDC. He did ask me to be on the editorial board, and I was for about 10 years. And so that was a great opportunity and a great honor. So what is it that brought us to that point? It didn't start until 1995. And so if we look back in time, these diseases that are referred to as emerging infectious diseases, in some cases re-emerging infectious diseases, really started in the 70s. And that term started to be used towards the late 70s. If you look in the literature, you'll find literally dozens of such diseases and agents that have been recognized and written about since that time period. I just picked a couple from each of the last 5 decades. So if you look at the 1970s, we talked a little bit about Legionellosis. Ebola also came out in the 1970s. It was first seen in Congo. You may be more familiar with the recent outbreak in West Africa, where it was in Guinea and Liberia and Cote d'Ivoire. But it was first seen in the Congo. In the 80s, we saw, of course, HIV surface, and we saw Lyme disease, which forever after today you will always refer to as Lyme disease with a Y. You'll never call it Lyme disease with an I, and you'll never call it Lyme's disease possessive. It's named after Lyme, Connecticut, because that's where the first case was identified. In the 1990s, Hantavirus disease was a newly recognized disease. At the end of the 90s, in the 1999, West Nile virus was seen. It wasn't new in the world, but it was new in the US in the 1990s. 2000, SARS is, of course, shows up on the horizon, and in 2003 it shows up and makes a worldwide tour. H1N1, which is a variant of influenza, which had a higher rate of morbidity, fortunately not so much mortality, in healthy adults. MERS is the Middle Eastern respiratory syndrome, so it's of the same category of virus that causes SARS. And then, of course, Zika. Zika was mentioned at dinner tonight, so great dinner conversation, Zika. So, first, a little bit of an overview quickly through these. Legionellosis. It's a bacterial disease. So emerging infectious diseases tend to be sometimes bacterial, sometimes viral, sometimes other microbial agents. It was first identified in Philadelphia in 1976, but now, today, 2019, is seen worldwide. It's a waterborne agent. So it's seen in air conditioning systems and reservoirs. And there has to be certain steps to be taken to make sure that it doesn't thrive there, because if it's there and gets pulled into the air conditioning system, that's the way people contract it usually. There are some community-acquired cases, but not many, because it tends not to be a very efficient person-to-person transmitter. A laboratory diagnosis is necessary, so the laboratory's role is very much part of the picture. It can mimic a number of other respiratory illnesses. So Legionellosis. We mentioned Ebola viral disease. So in 1976, in Congo, this was first seen, and a very scary agent. It's tough to figure out mortality rates in humans, because to truly test a mortality rate, if you do it in animal populations, you can control and you can look for deaths and follow the deaths. But for humans, you have to kind of estimate what the mortality rate is. But in Ebola, it has a mortality rate or fatality rate of up to 90%. So it's really a scary agent. It's easily transmitted person to person. It causes a condition which is referred to as a viral hemorrhagic fever. So it's caused by a virus, and it causes hemorrhaging. And it causes hemorrhaging out of every orifice. So you have individuals whom I've never seen in person, but have seen pictures of, who are bleeding from their eyes, their nose, their mouth, their ears, every possible place where blood can get out of their body, they have hemorrhaging. And the blood contains the virus in high numbers. So if anybody is trying to help this person, and in the case of the cultures of sub-Saharan Africa, where people are attending to their dying relatives and wrapping their bodies and cleaning them, they're at huge risk for getting Ebola. So it's a very scary disease. It's also one which, if there are enough cases and if there's an outbreak, a clinical diagnosis is probably not going to be inaccurate. It's probably going to be accurate. But if there are a few cases, and if it's early in the outbreak, laboratory diagnosis is critical. But because of the highly pathogenic nature of the virus, you have to have a really high containment level laboratory, which most developing countries would not have. So you need to have those things in place. As you know, and we'll come back a little bit, Ebola has come back, and it's actually circulating right now again in Congo as we speak. So it's not at all anything that's gone away. HIV infection. So HIV infection, again, first seen in the US around 1980 rather, mainly on the West Coast and East Coast, first seen in several populations. It's amazing to me how quickly we kind of identify people and kind of look at groups that were identified as having AIDS, which was called AIDS first, acquired immune deficiency syndrome, only because they didn't know what the virus was. But there were individuals, men who had sex with men, so homosexuals were viewed as at risk. There were some cases that were first identified from Haiti, and so Haitians were first inappropriately mentioned as a risk group, even though that was premature. Hemophiliacs were identified, and hemophiliacs were identified because without factor VIII, they had to receive transfusions with blood products which could have come from people who were HIV positive, and they would contract HIV that way. And then the last one was heroin users, so basically people who were intravenous injection drug users. So if any of you ever saw the movie Philadelphia, it's a great movie with Tom Hanks, and it's a true story about an attorney who was fired because he was HIV positive. And they make the case in there, they try to make the case that the ones who were justifying firing him was that they put a person up on the stand who had acquired HIV as a hemophiliac, and telling her that, well, you got it, but it wasn't your fault. You know, you didn't do anything that put yourself at risk. So we should feel sorry for you, basically. And then for the individual who was a gay man, basically they tried to paint the picture that he was deserving of this disease, which is, just such a horrendous idea. But it's been a disease which has gone around the world. We in the US, as I said, we had tests in 1985. We didn't really see the development of antiretroviral treatment for HIV until the mid-90s. And I can recall being at a meeting with the commissioner in Vermont, and our AIDS program director came in, and he'd just come back from an international AIDS meeting where they were talking about antiretroviral treatment. And he was saying that we can now be comforted in knowing that AIDS is a treatable chronic disease, which to me was another inappropriate and premature statement. Plus, it didn't acknowledge the fact that it only was a treatable disease if you had the $21,000 a year that required to treat it. And that certainly wasn't the case in most of the sub-Saharan African countries where AIDS at the time was running rampant. Finally, 2003, again, I was talking about this, I guess it was with the public health group today, the students, that in 2003, under President George W. Bush, actually, we had a President's Emergency Plan for AIDS Relief, a program called PEPFAR, which is still in place now 16 years later, and which has been an enormous positive for dealing with HIV on a global scale. It does support things like testing, but it also, identifying cases, but it also supports treatment. And it also supports care and support for those individuals who have contracted the disease. So it really was 8 years after the medications were available, finally we decided that we would treat people with HIV other than those in the US, but it was a huge positive step forward, and still is. I included the next slide, and I apologize because my work in global health goes back long enough that I still have regular Kodachrome slides, and I have pictures that are not on PowerPoint. But I did pull this out of my slide box someplace, and it just speaks to the issue of stigma and what it means for somebody in a developing country to have HIV identified, or what it means anyplace to have HIV identified. I have a good friend whose brother moved to San Francisco. He was obviously a gay man who was in a relationship, contracted HIV, AIDS, died, and his family, his parents, his sisters basically were unmoved. I mean, basically it was tragic to me that people could have that feeling towards somebody of their own family. But this statement, which is on a place called the Family AIDS Caring Trust, which is in Mutare, Zimbabwe, the eastern side of eastern edge of Zimbabwe. The line at the third line down, I think, says, "My friend who has AIDS remains my friend." A very important belief to hold. Lyme disease. I mentioned Lyme disease before. Lyme disease is a vector-borne disease, so it's transmitted by a bacterium, but it's transmitted through ticks. And the story about this is fascinating. It's a troublesome disease because the laboratory testing is not perfect. And so people who develop Lyme disease, if they don't produce a classical rash and are detected clinically and tested early on, the testing can sometimes be inconclusive. And so you can only have kind of a high level of suspicion or confirmation that you had the disease, but it's a bacterial disease, as I said, so if you treat it early with the proper antimicrobials, you can actually deal with it. If you wait too long, then it has what are called sequelae, or things that follow up, which are long-lasting and have nothing to do with the infection. They follow long after the infection's gone. And those things include things like arthritis, or a syndrome similar to chronic fatigue syndrome. What some people have done, which is, to me, horrible, these are healthcare providers, have used the ignorance, I would say, of their patients to say this is a bacterial disease and you're having this arthritis and fatigue, you just need to have a longer course of antibiotics. Absolutely wrong, absolutely the wrong approach, and deceptive and I think unethical. The woman who actually is credited with pushing on this was the mother of a boy who I think he was around 14 at the time, who lived in Lyme, Connecticut, and had this unexplained development of arthritis at his age, which made no sense. And so the physicians really didn't have a good answer, and I think she pursued it to the point of even raising the idea that they had a lot of ticks around their town. Could that have been some contributor? So the follow-up studies with epidemiologists and microbiologists and entomologists really revealed what the real story was. It's a problem. It's actually a problem which now is spreading throughout not only just New England but elsewhere. And in Vermont, where we have cases, the cases have risen each year of late because of increasing temperatures that allow the ticks to overwinter. So all comes together: climate change, public health, vector-borne diseases. Hantaviral disease. So this is a disease which in 1993 was one of 3 diseases that were, I think this is the year that everyone said, wow, we really do have a problem here. So in 1993, we had 3 outbreaks which were notable in the public health communicable disease world. One was in Milwaukee, where we had an outbreak of something called Cryptosporidium, which was spread by cattle, and the cattle depositing the Cryptosporidium cysts into the water supply, and many, hundreds of thousands of people getting sick with cryptosporidiosis, realizing that we didn't have the right systems to deal with this in the water supply. There was another outbreak in California that occurred in a Jack in the Box restaurant. It was people who were eating hamburgers, and they were hamburgers which were not fully cooked through, and they developed something called a hemolytic uremic syndrome, which was caused by an E. coli strain 0157H7. So those were unsettling. This hantavirus was discovered in southwestern U.S. in the Four Corners region, where people who were living in cave dwellings or the native dwellings that were on the cliffs and so forth, that they had rodents in there, and this is carried by rodents, and the rodent feces actually have the virus, and when you stir up dust and clean or whatever, you can breathe it in and acquire hantavirus. It's now been seen in every state in the country. So it's clearly a virus which continues to find a way to infect us on a regular basis. West Nile virus showed up on our shores in 1999 in New York City. It was never before seen in the US, had been seen elsewhere. It was causing encephalitis in horses. It was causing death of birds. It was causing febrile illness and, in some cases, encephalitis in humans. It truly was a disease. It's a vector-borne disease. It's caused by a virus, but it's transmitted by a mosquito. The laboratory has a huge role in this. It really kind of was a forerunner of some of the talk about One Health. The veterinarian who was at the Bronx Zoo at the time was instrumental in breaking this story open. It wasn't a CDC epidemiologist or laboratory person for that matter. The CDC had said this agent was St. Louis encephalitis virus, which we all have seen in the US and has been around and wouldn't have been a big issue if this was an outbreak of St. Louis encephalitis. And she said based on the birds that were dying at the Bronx Zoo, it wasn't St. Louis encephalitis because they weren't susceptible. So she insisted on follow-up work, and she sent it out to UC Irvine, where they specialized in certain arboviruses, and they identified it as West Nile. So again, if you look at the history of this, once it was embedded in New York State and the virus was there and the mosquito vector was there, it just moved across the United States. You could see every year, you'd see it move farther and further west. So it too has now been in every state in the Union, West Nile virus. The next one I wanted to just chat about is SARS. And so This was in 2003 that SARS showed up, and it's a difficult story because it first showed up as a severe respiratory illness in China, but it wasn't reported to the world community for about 6 months. By the time that it was reported and the WHO was brought into the discussion, it had really kind of gone out of control. It traveled across the world, reached the borders of the US, and really caused a high number of highly ill individuals. It was caused by a virus called coronavirus, and coronavirus prior to that had really been thought of as only one of the many viruses that can cause cold-like symptoms. But this is much worse than that. So SARS was kind of an eye-opener for the World Health Organization, and it resulted in some changes in the international health regulations, which I'll cover in just a moment. In that same decade, 2000s, we had influenza, and for any of you who study microbiology or know anything about microbiology, or have read about the history of the 1918 influenza pandemic, influenza is an incredibly challenging foe for humans. It is easily able to change antigenically, so your body is not protected from one strain to another. It goes through two different levels of change. One is called antigenic drift, which is a minor change, or antigenic shift, which is a major change. And so when there's a major change, virtually everybody who is on the planet is susceptible. And so the fear is that we're going to have a strain at some point, and it was thought that this would be it, H1N1, that actually will be very severe and have high rates of morbidity and mortality. Fortunately, this was not as high in mortality, but it was pretty high in morbidity, and it also, for the first time in quite a while, changed the demographics of the people that it attacked. So rather than simply the very old and the very sick and the very young, it attacked individuals who were college-age students. So we've actually, since that time period in the 2000s, made sure that H1N1 strain is always in the vaccine that's out there being circulated. So influenza, people want to know how we're going to protect ourselves, how we're going to prevent a pandemic, but actually, sorry to tell you that we don't have the answer to that. It could happen. Middle Eastern respiratory syndrome, again, another coronavirus, another respiratory illness. This one seems to be a zoonotic disease in that it probably comes back and forth between humans and camels. It's unclear about the transmission, so there's still a lot of work being done on MERS, but it just kind of is one more example of a new disease showing up on our doorstep. Finally, I want to talk about Zika. And so Zika is another viral disease, one that actually was discovered in sub-Saharan Africa 50 years ago. So it's not that this is a new virus that hasn't been out there, but I think sometimes, many times, we don't really pay attention to a virus until it gets closer to us. And so Zika, through changes probably in the host range, not the host range, but the vector range of the mosquito that transmits Zika, showed up in this hemisphere, so showed up in South America. And what was noticed about 5, 6, 7 years ago, I think it's been less than 10, was that women who have Zika during the first part of their pregnancy are much more likely to have a microcephalic child. So suddenly we paid attention, first of all, because there was a concern about the outcome of a pregnancy. Second, because South America is closer to us than sub-Saharan Africa. So we suddenly geared up for Zika testing and have done Zika testing in the US now, particularly in the South, because there are places where Zika can be transmitted. Again, we have problems because the testing for Zika, there was no laboratory developed test, there was no commercial test for Zika. The CDC put together a test for Zika, distributed to the public health community. And there actually was a tragic situation in one of the public health laboratories where all of their tests were falsely negative. And they did find out after the fact and correct the problem. But some people were speculating, what if they had been falsely positive? Because you think about people who would have acted on that test and possibly even terminated pregnancies as a result. So it's a laboratory test. It's not perfect, but it's I think now recognized as to some of its shortcomings. This is the last kind of emerging infectious diseases that I wanted to mention. I didn't want to leave the subject before I mentioned this group, neglected tropical diseases. So we get very concerned about emerging infectious diseases and re-emerging infectious diseases, but this is a group of diseases which haven't re-emerged. These have been around for a long time. These are diseases which are mostly in resource-poor countries. They're usually parasitic. They're very much associated with poverty. In the aggregate, all of these afflict about 1 billion people, which is a seventh, over a seventh, or about a seventh of the world's population. And one would think that we would be doing something about a group of diseases which was that, that common and that, that devastating in terms of and they're really horrific. And some of them can cause death. Many of them can cause lifelong deforming and challenging physical conditions as a result. Some of them that I have listed here, just to show you how many there are, you might recognize. For example, the third one actually is bacterial disease. Hansen's disease is another name for leprosy. And people think, well, leprosy is not something from biblical times. Isn't it gone? No, it's not gone. It's still around in certain parts of the world. The first one at the top, I should mention only because that one is interesting. It's a disease which is transmitted by this worm, guinea worm, which goes through only one other secondary host, which is a water flea. And then humans consume the water with this microscopic flea and the parasitic eggs in it. It finds itself into the gut. It matures in the gut, mates in the gut, and then migrates down through the lower extremities, and it can take months, and then finally be extruded outside of the leg. It's a terrible disease, and it's painful, and it's very preventable. And Jimmy Carter, to his credit, has actually done a great job of showing people simply, if you filter the water so you can take out these microscopic fleas, you can interrupt the transmission of this disease. It's closer to being eradicated, actually, than polio. It would be the first disease of humans that would be eradicated without the assistance of a vaccine. So I hope he has success soon. I hope it happens before he passes on. One of the things that is used in global health all the time, and this is an example of where these neglected tropical diseases is what's called the global south. So we use the term the global south. So all the areas in red are areas where neglected tropical diseases are more likely to be occurring. And many of the global health problems that we see are found in the global south. And the global south, again, reflects the preponderance of countries which are low and middle income. Just a couple of weeks ago, as I was thinking about what I was going to say, the New York Times, I do still get the Sunday New York Times. I do read a paper. I'm that old. So I see this on the front page of the New York Times. I had heard about this organism a couple of years ago. It's a yeast candida. It's related to the same yeast that causes candidiasis, yeast infections, sometimes vaginitis, sometimes oral thrush in young children. But it's a different species. It's called Candida auris. And so it's a serious concern because it tends to be resistant to most antifungal agents. And it does sometimes colonize places like hospital bedrooms and get into patients who are immunocompromised. So it's an example of yet another emerging infectious disease. So let's move on quickly then to World Health Organization 10 threats to global health put out this year. It's not too readable there, I guess, the bottom line, but the one that I highlighted is antimicrobial resistance. Notice that there are some of these that you would expect to be on here, like climate change, non-communicable diseases. Influenza pandemic is still on the list. I mean, it's a concern each and every year that this could happen. Fragile and vulnerable settings, so that has an impact on individuals and their susceptibility to these diseases and problems. And then Ebola and other high-risk agents is another concern. Poor primary health care. So again, I think it was in the population or the public health course this morning, we talked about pneumonia, and the fact that children under 5 in developing countries can die of pneumonia because they don't have good primary care, don't have access to antimicrobials. Vaccine hesitancy, huge problem. Dengue. Dengue is a virus we haven't talked about. It's a vector-borne disease. It too, I think it was 20 years ago, was on 2 continents, now is on 5 continents. Part of the problem is the vector, a mosquito, is spreading because of climate change, and therefore the virus will tag along and cause disease more widely. And then, of course, HIV. So what about antimicrobial resistance? So we could spend some time talking about the difference between antimicrobial and antibiotic, but I'm not going to get into that. We can just kind of use them synonymously. So what happens? How does this happen? Why do people have problems with antimicrobial resistance? Well, overuse, overprescribing is one area. Patients not completing their medications and allowing a antimicrobial to not be fully effective against an infection is another problem. Overuse in animal populations for years, and it's still going on despite attempts to try to stop it. Animal populations that are treated broadly with antibiotics were treated both to reduce the disease levels, but also it turns out that antibiotic treatment tends to be a growth promoter. So they've been used in the agricultural industry, and that's resulted in a large number of antimicrobial resistant agents coming out of that population. Poor infection control in hospitals, another issue. Not having good sanitary conditions or hygiene, another issue. Or just the lack of antibiotics being developed. If we look at what's happened over the last several decades, you can see how antimicrobially resistant trends have gone up. Whether you look at something like methicillin-resistant Staph aureus or MRSA, or vancomycin-resistant enterococci, which is VRE, or even this one agent that was used in treating Pseudomonas aeruginosa. Every one of those is on an upward track. And again, we sometimes mistakenly don't appreciate the magnitude of the problem until it's a little bit too late. For a long time, we thought that MRSA was simply a problem of healthcare facilities. And then in the 90s, we realized that it really could be a community-acquired infection. And now it's just rampant right now. Then we look at the other side of the coin and we look at, all right, what about the production of antimicrobial agents? Well, this has been on a decline, on a serious decline. And everyone who's written about this has indicated that it's no surprise that if you're in pharmaceutical business and you have a choice between producing a medication which is going to treat something like diabetes or high blood pressure, and somebody's going to be on that for years, if not life, or you're going to produce an antibiotic which is going to be used for short-term use and treatment and then discontinued, what are you going to choose? Well, I think pharma has clearly chosen not to go after new antimicrobials. I think that's something which at some point we're going to have to look at from a health policy standpoint, at least at the US level, and try to decide what are we going to do to create the incentive to develop more of these antimicrobials. The other problem is just what happens with the agents themselves, the microbes. There's a great quote which I could not locate, which talks about a fight, an ongoing fight or battle between humans and microbes. And it's unfair because the microbes are better armed. And that's the case, and they can show us this here. So you look at penicillin, tetracycline, methicillin, all the way down to ceftaroline, and see that the time between introducing the agent into clinical use and the first appearance of clinical resistance has been as short as a year, on average less than 10 years. So we need to find a way to not rely, obviously, entirely on new antimicrobials, because that's not going to be the only answer. Another problem that's related, and we don't necessarily think about it as such, and that is agents that are not antimicrobials for human use, but actually have the impact of giving selective pressure on organisms to select out for resistant organisms. I can recall in the 90s being in some panel talking about antimicrobial resistance, and there was concern expressed about this agent, triclosan, which was produced as an antifungal, antibacterial agent that could be used in non-medicinal uses. Wasn't intended for human consumption. So it was put into clothes and cookware and furniture. And at one point, I think we were so germophobic as a society that we wanted antibacterial everything. I can recall being put on toothbrushes. And then they actually started putting it on toothpastes, which actually do get into the body. So finally, because it was intended for human use, it fell outside of the scope of the FDA's control. But once they started putting in things like soap and toothpaste, then it came under the FDA control. So there now actually is some restrictions on the use of triclosan. It causes disruption of the membranes of microbes, which is similar to the actions of some antimicrobials that are used clinically. So it can cause the selection of antimicrobial agents without ever being used for a treatment of a case of anything. 75% in a study done about a decade ago of adults and children showed triclosan being excreted in their urine. That's crazy, that we have this agent so prevalent in our society. Some things that are going on, some not so really pleasant and very disturbing, I would say. A British study regarding antimicrobial resistant trends recently projected that by 2050, if the trends continue as they are, the number of people who are dying worldwide from infectious diseases because they're untreatable, will exceed the number of cases of cancer. That's 30 years away, so that's scary. Antimicrobial stewardship is going on. A lot of hospitals are looking at what can be done. That's okay, but it's just part of the problem. Patient and healthcare provider education, again, part of the issue, but boy, it's tough to do that, and it's tough to change behavior. Animal and human use, animal use particularly, needs more monitoring. Environmental uses and things like triclosan. Disease reporting systems tend not to include antimicrobial resistance as a common factor. It needs to be on a regular basis. Over-the-counter purchase. You can go to developing countries and buy antimicrobials over-the-counter. So that's terrible. So there are this is a complex area and a complex crisis, but it's something where we need to be doing something, and many people need to be involved, not only the laboratory, but obviously including the laboratory. I want to just mention a couple of things before I wrap up. One is this whole concept of One Health. About 14 years ago or so, the American Veterinary Medical Association and the American Medical Association got together and talked about the need to work more closely in having human health scientists and clinicians work with animal health professionals and scientists, and also to include environmental scientists, because it's clear that the impact of environmental change on human health is evident. The impact of human actions on the environmental health is evident, and animals as well. So we need to be working in that direction, moving in that direction. Some of the things that I've been involved with and am going to be involved with going forward do take into account that idea. So the international health regulations were changed in 2005. I mentioned SARS in 2003. So the World Health Organization realized in 2003, what if SARS had broken out in some developing country where they didn't have adequate laboratory or epidemiology infrastructure? It would have been even worse than it was. So there was a new set of regulations and a new World Health Assembly declaration, which basically said that within 10 years, all countries would have basic capacity in laboratory and epidemiology infrastructure. Well, in the 2013, 2014 or thereabouts, when the outbreak of Ebola came about in West Africa, it was clear that we weren't anywhere close to that. I think only about 20% of the countries in the world actually have met the standards that were laid out. So it's a huge challenge, and it's one that needs to be addressed. Part of the ways in which it needs to be addressed is through systems. So laboratories that work together in a system, whether it's a formal or informal system in countries. So making sure that you have public health laboratories, clinical laboratories, animal laboratories, all of those working together to address the challenges. One of the things that was recognized in the Ebola outbreak in West Africa as well is that it wasn't always the case, or necessarily just the case, that individuals didn't know how to do a test. They may know how to do a test, but there was a distinct lack of experience in running laboratory systems and laboratories in general. So the WHO now, along with 5 other agencies, is putting together this global laboratory leadership program. And you'll see that the things that they're trying to develop in terms of skill set for knowledge, skills, and abilities doesn't really have anything to do with how to do a test, but it's how to run a system and build a system, how to lead a laboratory and a laboratory system, how to manage, communicate, quality management. Some of these things were the same things we talked about today with the new master's program that Hartwick is putting together. Biorisk management, disease surveillance, all of these things. So there now is a set of competencies which are outlined. Right now, the same group, and I'm involved with this, is helping to put together training materials so this can be piloted first in Pakistan and then actually in Liberia. So hopefully that will help us move forward. One other thing I've been involved with is the publication of this new Control of Communicable Diseases laboratory practice, which is going to be a companion volume to a book called Control of Communicable Disease Manual, which has been out for about 100 years now, but actually has focused always on epidemiology. Finally, with the help of the American Public Health Association's press and Dr. David Heyman, we're able to bring the laboratory's role in communicable disease surveillance and prevention to the fore. I just throw you this up because this was a laboratory in Zimbabwe where not this gentleman who was another colleague from the US, but those things on the right side are TB specimens. This is the kind of staggering, kind of overworked, and this was one individual, was the only individual in this hospital laboratory of about 100 beds. I can tell you right now, having directed a TB laboratory, there's no way that one person can look at that many TB specimens in a day and do it justice. So that's the kind of challenge that we're talking about. We are talking about trying to reach a point where we have quality reference laboratories at the country level. So communicable diseases remain a threat to global health. Global health is public health on a global scale. If you go back to the Institute of Medicine in 1988, they said public health is what we do as a society to create the conditions where people can be healthy. That definition, to me, applies to global health as well. We are a global society, we are a global community, and the things that we do as a global community to create the conditions for people to be healthy is what we need to be doing. Controlling these and preventing these diseases requires obviously a lot of different groups and activities and sciences, but laboratory science is right in the middle. I want to end with something. I said I worked at Maimonides Medical Center, so I'm going to use Maimonides, who was a philosopher on health issues. May there never be developed in me the notion that my education is complete, but give me the strength and leisure and zeal continually to enlarge my knowledge. President Dragovich said at dinner tonight that we all have this opportunity to always continuously expand our knowledge, and I would just hope that we use that expansion of our knowledge to address some of these global health challenges. Thank you all very much.
So we have time for questions, and I will run around with the microphone for anyone who wishes to ask a question.
Okay, hi.
Hi.
I was just wondering if there are alternatives to treating infectious disease besides antimicrobials and antibiotics.
In some cases, yes. I think some diseases are self-limiting and not necessarily require that. If there is such a disease, in fact, with some gastroenteritis diseases, that's actually preferred because treatment with antibiotics can actually sometimes extend the time that you're infectious. So, but that's almost a culture shift as much as a scientific shift. Not only do healthcare providers feel the pressure to treat, but patients oftentimes inappropriately and unknowingly expect to be treated. And you will hear physicians say, well, I might as well treat because if I don't treat them, they're going to go to the next physician and that person will treat them. So yes, I think one needs to use them judiciously. One needs to use them only when it's scientifically justified. And I think it's a challenge. It's a challenge.
Bert.
Yes.
So the slide you showed of the clinical laboratory where you have all these tuberculosis samples waiting to be tested. So clearly in under-resourced parts of the world, there's the knowledge about what they need to do, but there's a lack of, because this happened in Liberia with the Ebola outbreak too, right? There was just a lack of adequate individuals involved in healthcare, and then most of them died of Ebola, and so it just enlarged the problem. So is it because there's a lack of access to education so that there aren't new people entering the pipeline? Or is the lack of resources generate a lack of funding to pay people who enter the pipeline? In other words, where's the bottleneck?
Sure.
The knowledge is there.
Right. And I can speak only to the countries that I'm familiar with in sub-Saharan Africa where any of those situations could apply. There are situations where you have excellent universities and you have excellent scientific knowledge, but you don't have the resources to pay people. There are some places in Zimbabwe, for example, where I know that they, in order to bring people who are working in laboratories out to remote regions, have to provide them with housing to make sure that they have a place to live. Otherwise, they can't afford to even be there. I think the laboratory tends to be, and this isn't just in developing countries, I think it's the US as well, that I think nursing care and direct care tends to be a priority over laboratory services. So getting the laboratory funded and having adequate workforce is a challenge. Workforce development is part of the international health regulations and initiatives that began in 2005. But it's frankly relatively easy to have 190 people in a room all nodding assent to say, yes, this is what we're going to do in 10 years, with no acceptance or recognition or dealing with the fact that the funding to do it and the mechanism to do it hasn't really been thought through. So I think finally, with the Ebola outbreak in West Africa, I think there is something of a final realization that this can't be something we just say we're going to do. There has to be some effort to make this a reality. And one of the places people have turned are foundations. And so foundations, and I was talking to one of the students today about not-for-profit and NGOs that are out there doing global health work. Foundations, and even governments for that matter, oftentimes look at something on a disease-specific approach. So we're going to have a malaria prevention program, or a TB prevention program, or HIV prevention program, or Ebola prevention program. What we need is a laboratory infrastructure development program and workforce development program. But that doesn't really sell, I think, in the areas of foundations and NGOs. It seems like it's not attractive enough. It's not glitzy enough, I guess. But I think finally the Gates Foundation is working with the African Society for Laboratory Medicine and giving them some money to support building laboratory infrastructure. So, I think I would be happy if PEPFAR, we talked about PEPFAR earlier on today, if part of PEPFAR, in addition to providing laboratory diagnostic services for HIV, would simply build laboratory infrastructure in countries as a byproduct of that, then it doesn't make any difference whether they're testing for HIV or malaria or salmonellosis or whatever. They'll have the means to do it. But that has been a long, challenging argument to make, unfortunately.
So recently there was an article released that said that the measles epidemic has reached probably the highest it has in America in about 25 years. And that was said to be contributed to many people who are not vaccinating their children anymore. With this huge wave of non-vaccinations, do you think that there are any diseases in the U.S. that we have said that we've gotten rid of that could make a comeback and have more consequences to them than we could think of?
There are. Measles is probably the most scary example because it's such an infectious agent. So the ability to transmit measles from one person to another is incredibly efficient and easy. So people don't realize just how infectious measles is. Also don't realize that people are likely infectious with measles before they ever show any rash on their bodies, so it makes it even more difficult to control. Don't realize that people die from measles or can end up having encephalitis or long-term consequences of measles. I think it's unfortunate to me that in developed countries, and even in some of the highest, richest, most intelligent parts of developed countries, that people have decided that it's okay now to stop, immunizing. You don't see that in most, you see that in developed countries, but you don't see it in developing countries. In developing countries, they still see measles and they still see children dying of measles. So they're not stopping vaccinating. They're better vaccinated. I was in Eritrea, I think it was, where the vaccine rates were higher than the state of Mississippi. So they're serious about immunizations and they understand the value of immunizations. I don't know. Right now, we were talking about this in some discussion today about the challenge in New York City, that there's a suit which is being brought against the city to prevent the city from mandating measles vaccination. If we go down that road, we're undoing public health progress, which dates back, decades and decades. I don't see an easy solution to this. I think it's going to require a massive push for public education. And I think it's going to require not a lessening, but a strengthening of public health laws. People won't like it, but I think that's what's needed. I think what may happen is the time which could be coming soon. I think we're at 500 to 600 cases already of measles. So on average, you have the mortality rate for measles about 1 in 1,000. So statistically, within the next few hundred cases, we should see a death. When somebody dies of measles, maybe we'll take it seriously.
First of all, I want to tell you how proud we are of you.
Thank you.
And all the work that you've done. And we're so grateful that you came back to share all of your wisdom and your knowledge with us. You're educating this community, and we can take that forward. And so thank you so much. I do have a question. You made a comment about the overuse of antibiotics in the treatment of Lyme disease. And I think you described it as irresponsible. Lyme disease is something that people here in this region have become increasingly concerned about, and I know personally a number of people here who have become very ill as a result of it. Is there an effective treatment, since we shouldn't be relying on antimicrobials? Is there a way to effectively treat this disease?
Not really. I mean, the best is prevention. And so the idea is don't get bitten by the tick that may have the Borrelia burgdorferi in it, which is easier to say than to do sometimes. That really is the key. I would say Lyme disease, also we talked today about tipping points. So we're not at a tipping point where Lyme disease affects enough people, I think, or hasn't caused enough distress with enough people for us to invest more money in better diagnostic tools, better laboratory tests that maybe can help people to identify ways to diagnose it earlier. And if not eliminating antimicrobial treatment, at least minimizing the length of time somebody's on antimicrobial treatment. I mean, once the disease has gone past the point of causing some of these long-term problems, it's no longer going to be benefited by antimicrobial treatment. That's the unfortunate truth, but it's something that a lot of people who are not scientifically knowledgeable aren't going to appreciate. And if somebody tells them, if you just had a 4-month course of antibiotics, you'd be better off. Well, it doesn't work that way. It's a challenge. I mean, I'm trying to think, I believe we did have a Lyme disease vaccine. We had a Lyme vaccine for humans. There were some issues with it, which I can't recall exactly what they were. It was felt, vaccination is always a trade-off. The protection you get versus any kind of side effects or consequences, or in some cases, non-protection. In Lyme disease with the vaccine, it was determined that whatever the problem was sufficient that we should just pull it off the market. Interestingly enough, we have Lyme disease vaccine for dogs. We vaccinate our dogs, so whatever the vaccine problems for dogs, we seem to have resolved those. Why don't we spend more money kind of investing in a better Lyme disease vaccine? So then those individuals who are in Lyme endemic areas will simply get the vaccine. Then you would never have to treat them because they wouldn't get the disease. That to me would be the wise thing to do.
Well, the great news is we've got a number of students in this room who might be up to that challenge.
They're gonna
exactly. Thank you so much.
You're very welcome.